to welcome everybody to this presentation on opioids. Our presenter today is Dr. Robert Vandermark, Jr. Vandermark is a past president of the SDSMA and a chair of our Special Committee on Pain Management and Prescription Drug Use. In his role, he has led efforts to address the prescription drug abuse, the publication of guidelines for physicians to effectively treat and minimize patient risk, treat pain and minimize patient risk. Dr. Vandermark is an orthopedic surgeon in Sioux Falls, and he is the head of the section of orthopedics and a professor at the Department of Surgery at the University of South Dakota School of Medicine. And keep lines on mute. We will open those up later in the presentation so you can ask questions. And at this time, I'm turning it over to Dr. Vandermark.
So the introduction, we'll kick off here talking about the opioid epidemic of 2018. If I can, so let's talk about the opioid epidemic. And to what can you do about this problem? The goals of our profession are to provide access for pain medications for patients, managed posed by prescribing those medications, also protect against opioid abuse, evaluation for opiate dependency and abuse, and initiation, monitoring, and review, and alternatives to opioids. Last year, the association received a grant from the South Dakota Department of Health. Goals of that grant to incorporate pain assessment tools, proper orientation, use MP as a practice tool. So it includes live presentations, which we started doing this year to various organizations, a web curriculum, which we'll talk about later, and a toolkit for opioid prescribing. Are addicted, estimated up to 36 million people abuse opioids in the world today. In the U.S., that's estimated to be about 2.1 million. It's double that number, no one knows for sure. There are about 467,000 heroin addicts currently in the United States. 80% of opioid users report that first regular opioid was a prescription pain medication. And 5% of heroin users first used an opioid. And of course, famous people dying from fentanyl, Prince, Phil Seymour Hoffman, and recently Tom Petty. And definition, the word opioids, it comes from opium, with joy, around for thousands of years, first cultivated in modern-day Iraq. And there are articles written about who really started the epidemic of opioids, and Hippocrates was a big user of opium after his patients became addicted. As far as goes, opiates are derived from plants. That's morphine, heroin, Vicodin, and Oxycontin. And the opioids are the synthetic medication, methadone, and now the fentanyl and its analogs. Oxycontin, which is probably the most dangerous drug we see, was developed in 1916 in Germany. One of Hitler's favorite drugs. In 1996, Purdue Pharmacy started selling that in the United States, and they have made $31 billion in profits from the sale of OxyContin. Opioid consumption, 80% of opioids are consumed by the United States. 99% of the world's hydrocodone, and we represent 5% of the world's population. It's estimated the U.S. consumed about 27 million grams of hydrocodone for the year. At the time period, the four countries of Great Britain, France, Italy, and Germany, a total of 500 grams for all four countries. And you say that, well, they use different medication for pain in Europe. Drug deaths in the United States last year, 2016, approximately 64,000 people died from a drug overdose. And since 2000, over 3,000 people have died of a drug overdose. And now drug overdose is now the #1 cause of death under the age of 50 in the United States. About 20,000 people died of fentanyl overdose. A number was heroin at 15,000, and prescription opioids came in third, about 14,000 deaths. A scary number is drug overdoses killed more people last year than the Vietnam War did. The problem of having combined drug overdoses with opioids and other drugs, alcohol, heroin, cocaine. It's a very messy subject now. And the problem now is fentanyl is being used to make counterfeit opioid pills. And sometimes this is very dangerous, and we'll talk about that. Therefore, by 2025, that will be about 20,000 overdose deaths from prescription medication and 72,000 from fentanyl and heroin. We're just starting to see the epidemic grow. And now the new problem on front is the elephant tranquilizer called carfentanil, which is a very dangerous drug along with fentanyl. The potency of opioids, morphine is a factor of 1. Fentanyl is 100 times stronger than morphine. And fentanyl is 10,000 times stronger than morphine. Economically, a milligram of heroin costs about $6,000. The value of that is $200,000. So there's a lot of cash to be made in the heroin market. Fentanyl, on the other hand, a kilogram is anywhere from $3,500 to $5,000 wholesale, and you make 1 million counterfeit pills from a kilo of fentanyl, and that has a street value of $10 to $20 million. So you can see why people are starting to sell fentanyl. So involved. Cost analysis of this, comparing OxyContin to black tar heroin, a milligram tab of OxyContin is $30. You buy 1 gram of tar heroin for $60, so you get a lot more bang for your buck. And of course, we've taken some blame for this because we are the ones who write the prescriptions. The old slide showing that most people get this medication free from a friend or relative, and that medication is written by 1 doctor. But there's guilt to go around. This drug firm, over a 10-year period, bought 20 million pain pills to a West Indian town of a population of about 3,000 people. That's how this all started. It is kind of a fascinating story. It really is a perfect storm when you look at it. In the 80s, Michael Jackson actually looked like Michael Jackson, and Reagan was elected president in 1980. At the same time, Herschel Jick ran a drug surveillance program at Boston University, and they published a letter to the editor about addiction being rare in patients with narcotics treatment. And he interviewed about that just recently, and he'd forgotten about the letter. And then when they explained to him the ramifications, he was disappointed because they didn't need to say that in their letter. But this is a letter to the editor. They looked at about 12,000 inpatients at BU Medical Center. Group 4 patients became addicted to narcotics, so it was a very low addiction rate, less than 1%. And so the statement was made in the note that addiction is rare. That has lived on in this article. It has been cited times in literature as narcotics, and especially the opioids, are safe with no chance of addiction. 5, Russell Putney was a pain specialist in New York. The Pain Society was founded. Purdue funded that organization. Pain became the 5th vital sign. In '98, the VA adopted guidelines with the 5th vital sign. Jacob also jumped on board with the 5th vital sign, and the guidelines for pain control were written by Purdue for Jacob. And then the document Responsible Opioid Prescribing was written in 2007 by the state medical boards, and a co-sponsor of that was Purdue. Opioid safety strategy slide for opioid stewardship. We think that one person should be writing the medications to check the statewide database to PDMP and use a set amount of opioids per diagnosis. We like to use opioids for new patients, opioids for chronic pain, or in gender release opioids. And we have, I think, reduced a prescription. This is from this year, looking at 2016. The numbers haven't gone down nationwide dramatically from 2013. And looking at South Dakota, we're a bit behind the curve, but we're still making progress going in the right direction. Wide opioid prescribing is decreased by 22% compared to 2013. South Dakota, we're a bit behind, down by 7%, but we are making progress. From the AMA, look at the opioid prescribing going down dramatically from 2013. Before I started doing this talk, I really never knew what MMEs are, and that stands for morphine milligram equivalent. And 90 MMEs is the magic number. Anything of that is a dangerous drug level. This is a diversion chart to convert your favorite medications to an MME. I have trouble remembering these numbers, so I just got the app for my phone. This is CDC opioid guideline. It's a free app. You can calculate your patient's MMEs very easily. Looking at MME prescribed per capita, South Dakota is in the lower quartile. Areas being high prescribers, a lot of areas being low prescribers. You see South Dakota, the black areas correspond to Russians. Overdose deaths nationwide, 2016. Once again, the darker numbers are the high overdose rates. South Dakota is pretty quiet. West Virginia led the nation in 2016 for overdose deaths, and South Dakota is next to last. For that problem. The golden line here is that the opioid crisis has made more organs available for transplantation. There's a fourfold rise in organ transplants from drug overdose donors. So really the problem is too high a dose. If you have a dose of 50 MMEs or more per day, that doubles the risk of overdose death compared to and at MMEs, it's a 10 times the risk of dying. 100 MMEs, it goes up to 11 times greater chance of dying. Prevent is a patient who's taking Oxycontin or codone and then doing Ativan and then start drinking at night, and those patients don't wake up. And that's what we're really trying to prevent in this situation. South Dakota Drug Monitoring Program, 2016. These are the top 10 prescribed medications in South Dakota. Number 1 is hydrocodone. Number 2 is tramadol. Number 3 is Ativan and Clonopin. Top 5 prescribed drugs. Then there are about 260,000 hydrocodone prescribed prescriptions for 17.5 million tablets. Compared to 2017, the top 5 are still the top 5. It's gone from 250,000 prescriptions to about 234,000 prescriptions. 4 million to 14.9 million tablets. The big question is, do we really need opioids? In a study from Holland in the United States, effective cohorts, fractures and hip fractures. In the United States, 82% of patients were discharged on opioids. In the Netherlands, 6% were discharged on opioids. They had equal pain relief, satisfaction with pain. Interesting, looking at hip fractures and opioids, 85% of patients in the states are discharged on opioids in the study, and 0% were discharged. You can realize the difference. Well, there's some medication available in Holland that we don't have here in all the states, and there's some good beer, but I don't think that explains the whole thing. And then ask yourself, does this really make a difference? Well, this is a study from David Ring looking at pre-op opioid misuse with increased morbidity and mortality. They looked at a data bank of Medicare patients from 2002 to 2011, looking at the diagnosis of opioid dependency prior to surgery for total hips, total knees, shoulders, and back surgery. And at that diagnosis, you have about 4 times chance of dying than if not, double the chance of a complication. So it does make a difference, especially in this medical population. This has always been used for chronic pain, and I think that has changed recently. This is a study from published in January looking at opioids are no better than other medications for chronic pain. From the VA Minneapolis, they did a study looking at chronic pain patients, low back, knee pain. They divided these into 2 groups, opioid and a non-opioid group, and the patients for 12 months. So the group, they were doing up to 100 MMEs per day, like a big dose of opioids, morphine, hydrocodone, oxycodone, morphine sustained action, hydrocodone, and then fentanyl patches. The non-opioid group, they used the usual non-steroidals, Tylenol, nortriptyline, amitriptyline, topical analgesics, and then gabapentin and tramadol. At 12 months, the pain and health outcomes were identical to both groups. Another group had better pain intensity. The opioid group had better anxiety symptoms, but also side effects. So I think the days of prescribing opioids for chronic pain probably don't have to be done anymore. This is a slide again looking at the single provider using the databases and then use that amount of opioids, and when we want to stay away from the opioids for new patients and chronic pain patients. This is a medication ladder. At the bottom, starting with the non-opioids, Tylenol, non-steroidals, and working our way up through the codeine and tramadol, and the stronger opioids is the last measure. This the Orthopedic Academy looking at pain relief for ER patients, looking at some common fractures that we see, hand and just this knee tibia plateau. They recommend a maximum of 10 pills for the ER visit. No codone, use steroidals as a first drug of choice, and then codeine for sleep. So you back up, you don't want to prescribe hydrocodone. And the problem is 5 days of opioids put you at increased risk for long-term use. There's also recent work now about women and tramadol, increased risk of long-term use. And then the patients using opioids for acute pain go on to a long-term problem. So this is a big problem. If it goes for greater than 3 months, you have a 15 times greater chance of addiction. It should be 3 days or less, and that usually take care of most of the patients for the pain control. Of course, the treatments for us as surgeons is a big deal. Peaks are the number 3 prescriber for opioids in the United States. We prescribe 8% of all the opioids. And there is that you can follow. This is just a PubMed search I did. There are about 200 articles talking about operative opioid prescribing. This is from JAMA. It had studies that they reviewed. Up to 67 to 92% of all pain meds prescribed were not used. So we are prescribing pain medications. This is from the Department of Defense in 2018, looking at some common procedures in opioid prescribing. Over 15,000 procedures. The mean use for opioids is 4 days, and about 10 of the patients got 1 refill. In addition, general surgery patients did opioids for 4 to 9 days, OB/GYN for 4 to 13 days, musculoskeletal was 6 to 15 days. So keep in mind if you're seeing those patients. This is just something new I just put in about South Dakota Medicaid now has a change to an opioid prescription benefit. And you have to get pre-authorization now for Medicaid patients for early refill. And there kind of talks about early refill, prior authorization for 1 long-acting and 1 short-acting opioid, or patient limits, MMEs, maximum authorization, and the coverage for medication-assisted treatment. So these are all available, I think, on the website. I don't think we have it on the association website yet. Anyway, we're talking about early refills. And this all is effective June 1st. And prioritization for 1 long-acting and 1 short-acting opioid starts July 1st. Any patient who is on high numbers of MMEs, you have to start do a weaning process each month and the schedule for that. So I think keep a lookout for it in the future. So that works out. I think to do some pre-op counseling and surgeons, we encourage non-steroidals before start medication. We want to know any problems people have had with opioids before we do surgery, and we anticipate 3 days of pain medication use and recommend Tylenol 3 for pain. And we coordinate with a primary care provider, especially if the patient's been using opioids before surgery. It's important, I think, to talk about the prescription drug monitoring program. By statute now, any person who writes prescriptions for controlled drugs needs to work with a PDMP in South Dakota. Actually, the real use of the PDMP nationwide has gone from a low number in 2014 to over 1 million plus requisitions. And I think this has been well received and very useful in your practice. This is the nationwide, the PDMPs, the South Dakota neighbors have a PDMP. Nebraska just passed a law in 2017, so they're now on that. If you're on the Avera Meditech system, you have a direct portal into the PDMP. It'll be one for both Sanford, I think, and for regional health to make sure to access the PDMP. So how do you sign up? It's just a Google search I did. I use a PDMP program for South Dakota. And looking at the second down here is a quick user guide, how to register for a new account. It's a pretty simple process, a 2-page form. You do have to have this notarized the time you sign up. I'll provide a clinical alerts for prescribers. Prescriber reports. This is a quarterly report, moral scorecard for your prescribing to compare you with your peers. This is a report card, my first one I got, talk about number of patients I prescribed. So we'll give you the your prescriptions by daily MME, and then all top medications prescribed. So I think it's the best way to compare yourself to on. And this MME again. This is an interesting fact I put into this dangerous combination therapy at the bottom. I've given people some Ativan before surgery because they're nervous, and then that shows up as a dangerous combination with opioids. Back is going to be a bigger deal in the future here. If we're getting more sites in South Dakota, you can just bring your medications and cash. The only drug take back Sioux Falls so far is at the Sioux Falls Police Station. I'm at our office, an opioid safety initiative. That's my PA started this to reduce medications, and we give the patient a brochure to read about the problem, and then they bring back their extra medication, and we dispose of it for them. The RX destroyer, which is activated charcoal, you put the pills in there, and it kind of destroys them. And then when they're filled, it goes in the trash. And we did that 3 months ago. We've taken back about 900 pills for prescribed cases in office, which has been a big deal. Education's importance. This is our website. So now we have a hyperlink, a prescription drug abuse, which you go to. There's for both providers and for patients. There are toolkits to talk about pain assessment forms, forms for other conditions, depression, anxiety, check for prescribing opiates for chronic non-cancer pain, M calculators, treatment forms, and patient education tools. And more importantly, probably is this resources for mental health services and addiction treatment. And this is the provider's website, so we've got those. We'll talk about available patient pain assessment forms, assessment for other conditions, education, management, and treatment services for addiction. Some tools are available: depression, anxiety, and positive outlook scale, general anxiety disorder, be GAD-7. It's a pretty straightforward questionnaire, numerical value of where the patient stands as far as depression and anxiety. Period risk tool, you can also use a numerical patients at risk. And employees is addiction services and treatment. We have names, locations, and phone numbers if you need help for addiction. And it's PM&R centers, drug and alcohol addiction treatment centers, medication-assisted addiction treatment, and mental health centers and helplines. So they donated us to use their education series on opioid stewardship, and a 4-part webinar with 4 modules to talk about opioids. And it's really a well-done series. If you get a chance, I'd have you look at that. And it's available on the website. Example what that looks like. You begin the course. Patients, this is their portal, talking about some of the frequently asked questions, prescription, drug storage and disposal, and the drug addiction services and treatment. So chronic non-cancer pain, things have gotten a little more complicated. So this is also by statute. There's standard medical records when you're prescribing for that chronic non-cancer pain, copies of signed informed consent, patient and psychosocial history, results of all physical exams and lab tests, confirmation that you checked the PDMP. And access to PDMP, you have to know why you didn't. And this will look at results of risk assessment and screening tools, a description of treatment provided, patient instructions provided to the patient, results of ongoing assessments, and results of evaluations and consultations with specialists. And then the third and last slide is information used to support initiation, continuation, revision, or termination of treatment, medical records, past hospitalizations, authoring for release of information to other treatment providers, and name, addresses, and telephone number of the patient's pharmacy. So it's got a little more difficult for that group of patients. Strategies here are to use evidence-based guidelines for prescribing, regardless of what the patient's situation is, process to assess, monitor, and communicate, and provide training, tools, and education for our providers. Opioid overdoses to increase availability for opioid dependence treatment, make social support available, use opioid maintenance treatments such as buprenorphine, and then support detox and treatments with opioid antagonists. Reduce inappropriate opioid prescribing and monitor our prescribing and dispensing. So, assess risk of addiction using a risk stratification tool, assessing function, behavioral health, and drug-related behaviors, gain informed consent for therapy, monitor gain and function, opioid risk, and progress toward treatment goals, and treatment agreements for long-term opioid therapy. And be sure to document that. So, PDMP, you find it helpful. You have the number of pills you write, and also the length of the prescription. Ladder, such a medication, non-steroidals, and codeine instead of opioids. 16 Americans die from opioid overdoses every day, and we need to reduce the amount of opioids prescribed. PDMP for prescribing and monitoring can provide adequate pain relief when needed. The real game is about 90% of patients who need addiction treatment don't have access to that treatment. I think this is going to be the big problem we're going to have to face. Proposals for this patient-centered opioid addiction treatment, PCOT, payment model. We'll see if that comes to be. But this really is a social economic problem, and I think the public health tools are really going to be the way to beat the opioid epidemic. So we increase access to mental health and addiction services, psychosocial support, and think about opioid maintenance programs with MLT of antagonists for that. So I'll finish my presentation. If any questions, we'll be happy to discuss those, and thank you for your attention.
Thank you, Vandermark. I did open up the phone lines. Do we have anybody online that has any questions for Dr. Vandermark? So phone lines are open. If you are unable to communicate or you're not being able to get through, you can also send us a note over here, but we do have them open. Dr. Vandermark, well, we'll see if anybody online has any questions. One question I do have for you is I was listening through your presentation, and I do orthopedic surgery primarily on the hand. How do you handle patients that come in preoperatively that you know has a drug addiction problem or has had a history of drug addiction? How do you kind of set them up so that you'll be successful with them and they won't have a relapse as they go through surgery?
Have that discussion as far as, I guess I try to treat those patients as a one-time event, that they do have a problem, so we try to stay away from the opioids. Fortunately, for a lot of things that we do in the hand, you can get away with doing Motrin, Tylenol, Aleve. A lot of people are taking a boatload of medications. I had a patient, in fact, this week who is about 300 MMEs per day is what he's on. To try to write a prescription on the computer, and a red flag came up and said no prescriptions allowed. So I told him, I said, well, you can Aleve and Motrin, but you're taking the stuff we prescribe and then some. So I guess I don't worry much about addiction or making them addicted because it's such a short-term deal. And we kind of tell people for a carpal tunnel, the average person takes 3.9 pills for the load. So I think if you lay that out in front that this is what we expect it's going to be, and it's like maybe 2 days worth of pain pills, and that's how we get around that.
Thank you. Once again, phone lines are open. Any questions for Dr. Vandermark or comments? Dr. Vandermark, hearing none, I think we'll go ahead and draw things to a close. But if he has questions, are they open to send you an email or giving you a call directly? Would you have a concern with that?
No, we'd be happy to talk to anybody who wants to get with me. It'd be fine.
Okay.
Yeah, my is at Sanford. It's Jr.@sanfordhealth.org. So
thank you. Appreciate it. One more time, put out there if there's any questions for Dr. Vandermark. Okay, and we'll draw it to a close. In closing, I'd like to thank Dr. Vandermark for invitation this evening, and for those of you that joined us online. The next program scheduled in this series is going to be on drug diversion. Our will be Pat Knight with the South Dakota DCI. One thing that Pat has done a lot of work in is working with hospitals and basically dealing with employees that they've caught with diverting. That presentation is scheduled for Tuesday, June 26th at 4:30 p.m. I'd also like to remind you that we have a number of tools and resources available for you to utilize for opioid treatment and prescribing on the SDSMA's website at www.sdsma.org. If questions, once again, I'll thank Dr. Vandermark for his presentation, and thank you all for attending.
Yeah.
Thank you.